Hello everyone, welcome to Dentomedia YouTube channel. In this video, you will learn about the 8 changes in enamel, dentin and pulp. So let's get started. Aging is defined as a process of morphological and physiological disintegration as distinguished from infant, childhood and adolescence, which are typified by the process of integration and coordination, and this is according to the Caries. Now we know the major tissues of the tooth, they are the enamel, the dentin, the pulp. So 8 changes are associated with these tissues. The completely formed teeth and the periodontium should remain intact and fully functional without any disease for a lifetime. So if we talk of the 8 changes in enamel, beginning with the first tissue, we have 8 changes at macroscopic and microscopic level. So at macroscopic level, the enamel becomes darker, attrited, abraded, eroded, and we can see longitudinal cracks. And microscopic level, if we talk of histological sections, we see decreased enamel rod ends, PERIKYMATA decreased, permeability to fluids is decreased, it becomes more of an opaque thing, increase in nitrogen and fluorine, and increased resistance to decay. Now discussing the macroscopic features in detail, let's move on to color. The color of the enamel becomes quite darker with age. It is associated with changes in the organic portion of the enamel, presumably near the surface. We have attrition, abrasion and erosion. So attrition is the physiological wear of the occlusal surfaces and the proximal contact points as a result of mastication, bruxism. So basically the physiological wear of the occlusal surfaces is attrition. It is evidenced by the loss of vertical dimension. The VDO decreases. Vertical dimension of the crown decreases, and even the proximal contour decreases. Where it becomes a contact point, it becomes a contact plane. It becomes more. So it becomes flattened. It is basically caused by a lot of masticatory stress or parafunctional habits. Now we have different stages of attrition. The stage 1 is wear of the enamel at the cusps and the incisal edges, but the dentin is still not exposed. Then we have to the stage 2, where wear of the enamel and exposure of the dentin will take place on the incisal edges, and we can see isolated areas of the individual cusps. Means whole of the dentin is not visible on the occlusal surfaces. What we get to see are isolated patches where dentin would be visible. Stage 3 is wear of the enamel forming a broad strip. It is going to form a broad strip on the incisal edges and the confluence of 2 or more areas of wear over adjacent cusps. So first, where there were patches, now those patches are going to become confluent. And we have stage 4, where the wear of enamel and dentin on the incisors, they form a plateau on the teeth to form a central area of dentin surrounded by a peripheral rim of enamel. There is just a thin peripheral rim of enamel, and entirely it is a plateau with the central areas of dentin. Moving on to abrasion. Abrasion is the pathologically wear of tooth through abnormal mechanical process. It is the pathological wear. It could be because of an abrasive dentifrice, the brushing technique followed by the patient is not apt, occupational improper flossing, so that causes abrasion. Talking of erosion is the tooth substance loss by chemical process that does not involve any bacterial action. Lingual erosion is mostly seen because of chronic vomiting, bulimia, acidic carbonated beverages intake, and there could be labial erosion. And the longitudinal cracks which would be seen, they may be developmental in origin although their numbers do not increase with age, but yes, they start becoming more obvious. Now, if we talk of site specific thickness of enamel, where the enamel is thick, thinning of the enamel at the level of the cemento-enamel junction, we know it becomes thinned, and thickening at the incisal edges due to wear with advancing age. Thickened at the incisal edge means maximum facial palatal width if we talk of buccopalatal, and these phenomena are going to result in decrease in height of the tooth's crown. So this is how there is site specific thickness. Moving on to microscopic changes, let's talk of perikymata. Perikymata are basically the transverse wave like grooves. They lie parallel to each other, and also they lie parallel to the CEJ. So the surfaces of unerupted and recently erupted teeth, they are covered completely. They have pronounced rod ends, and perikymata is clearly visible. But with advancing age, what happens? There is generalized loss of rod ends, and it shows slower flattening of the perikymata, and eventually what happens? This perikymata, they are lost. So this is very important, that with advancing age, with newly erupted teeth, we get to see perikymata, but with advancing age, they become flattened. More rapid loss of structure, facial and lingual surfaces of the interiors. So we can make it out through the diagram. We can see the enamel rod ends pronounced. Now we have fewer enamel rod ends as the tooth is advancing. Now the permeability to fluids and water content, now due to lot of acquisition of ions from the oral fluids. It's a mature tooth. Geriatric teeth are mature teeth, right? The crystal size are going to increase. So if the crystal size is going to increase, there is going to be reduction in the pore size. The pores are going to reduce. They're going to reduce in volume, in surface area within the substance of the enamel, and that is responsible for decreasing in permeability and water content. There is continuous deposition of fluoride and nitrogen, increase in fluoride concentration of the enamel, and hence geriatric teeth are increased resistance to decay. Hardness and elastic modulus of enamel increases the brittleness of the teeth because permeability is decreased, and we get to see a lot of cracks. So moving on to age changes in dentin, we get to see two major changes in dentin. There is lot of formation of secondary dentin formation, reparative dentin formation, and we see sclerotic dentin. We have dead TRACTS, we have sclerotic dentin, means the sclerosing or obturation of the dentinal tubules. So secondary dentin forms after the complete formation of the tooth. Now the types, there could be physiological secondary dentin, it forms with normal stimulus, or it could be a reparative secondary dentin which forms with either a traumatic or abnormal stimulus. So it could be reparative or it could be physiologic. So now the types of secondary dentin, comparative evaluation if we talk of the regular and irregular. So the regular secondary dentin, that is physiological, is caused by mild stimulus, like the patient is slowly attriting, slowly progressing caries. But in irregular, it is severe stimuli, severe attrition, erosion, deep caries lesion. If we talk of the site of formation, that involves in the regular, it is the entire pulpal surface. It is thicker on the roof, thicker on the floor. But their site of formation is localized to like pulp horns, one specific pulp horn, like the mesial pulp horn could be obliterated or the distal pulp horn could be obliterated depending upon where the tooth received the stimulus. If we talk of the tubules, they have a wavy course in the regular one and decrease in number. But in irregular, they have wavy and twisted course. They are also decreased in number or they're atubular. Clinically, if we see the increase of dentin thickness and the closure of the pulp horns make it less possible to expose the pulp chamber. So during preparation or anything during preparation of the teeth, we go for crown preps or anything, there is less chances of exposure of the pulp because overall the thickness of dentine is increased. And if we talk of the irregular, that is reparative, it functions as a barrier against caries. So physiological regular secondary dentine, we can see the primary dentine is shown in red, carrot red color, and the secondary is shown in mustard yellow. So the secondary dentine deposition is a major factor whenever we go for crown preps or any cavity preparation as well, tooth preparation. The exposure chances are quite less because of lot of dentine deposition. Now the reparative or reactionary dentine is, how is it formed? We see that there is extensive abrasion, extensive erosion going on, caries operative process. So because of that, we can see odontoblasts, they are cut. Now odontoblasts are cut, either they live, when they live they form reactionary or regenerated dentine, or they are degenerated or they are replaced by the migration of undifferentiated cells, means there is migration of undifferentiated stem cells again, and from the cell rich zone of the pulp they come and they start laying down the reparative dentine. So this is how they are formed. Talking of the dead tracts are basically the odontoblastic cell processes in the dentinal tubules. They are degenerated. Once they are degenerated, they leave behind empty air-filled tubules referred to as the dead tracts. They appear black in transmitted light and white in reflected light. It is a very important MCQ question. Quite confusing. They confuse it with the light. So it is black in transmitted light and white in reflected light. Probably the initial step to form sclerotic dentin, demonstrates decreased sensitivity. So we can see the translucent sclerotic dentine. In the picture, it is shown there's a young dentine, there's an adult dentine, and there is sclerosed dentine. So any physiological change in the primary or secondary dentine, it is going to get more initiation towards mineralization, harder and denser than the normal dentine, seen first at the root apices. It will be seen at the apex in middle-aged persons, spreads upwards with advancing age, comes near the chamber. And this is one of the criteria used in forensic odontology to assess the age of the individual, because it starts from the apex and then it goes upwards. So it can be used in forensic odontology as well. So talking of the sclerotic dentine, it appears light in transmitted light and dark in reflected light, and that is how they confuse it with the dead tracts. So make sure you do this nicely. Now, so if we talk of the young tooth and an old tooth comparison, we can see in an old tooth a receded pulp chamber, very clearly visible increase in width of the cementum and lot of secondary dentine deposition. So this picture says it all. Now the age related sensitivity changes. Secondary dentine grows inwardly into the pulp chamber. So if it grows inwardly into the pulp chamber, it is going to decrease the size of the chamber. The tubular lumen becomes obturated with peritubular dentine, means the dentinal tubules are going to become they're going to become closed, or they're going to get obturated by peritubular dentine deposition around them. And by the age of 80, all dentinal tubules, almost all, they are occluded. Decrease in sensation to hot and cold stimuli. Now, moving on to the last part of this topic is age changes in the pulp. Now, reduction in the size and volume of the pulp as a result of continuous deposition of dentine. That means continuous deposition of dentine is going to decrease the volume of the pulp. It is going to decrease the size and volume both. So, decrease in the number of cells and apparent increased fibrosis with time may not be from continuous deposition of collagen, but may be due to presence of connective tissue in increasingly narrow pulp space. So there is increased fibrosis. No doubt there is continuous deposition of collagen taking place, but there could be persistence of connective tissue sheath. Cellular composition of the pulp is modified completely. the fibroblast present in the cell-rich zone of the pulp, the odontoblasts, everything. Cell-rich, they are going to show degeneration. There is going to decrease in size and decrease in the number of organelles. Ultrastructural studies reveal an increase in the vacuolar numbers and gradual degenerative changes leading to complete absence in the cells. So changes in the vascular distribution, there is narrowing of the circumference of the blood vessels, atherosclerotic changes are seen, and the intimal layer of the vessel, they are thickened, the intima resulting in quite small lumen. If we talk of the nerve distribution, there is going to be degeneration and loss of pulpal nerve fibers, and that can affect the transmission of pulpal structures, resulting in increased thresholds. Means that patient doesn't feel pain easily. There is going to be increased thresholds to pain stimuli, and the myelin sheath changes and terminal axon remolding due to age-related axon injury could be sources of abnormal pain in the oral region. Now moving on to the pulp stones, it comes as a separate note. Pulp stones are nodular calcified masses. They are nodular calcified masses. Either they can be in the coronal or the root portions of the pulp organ. So they can be true or false. True means they are made up of dentin. They have dentinal tubules in them. They are lined by the odontoblasts. They are closer to the root apices, and false means they are just calcified masses, degenerating cells. They mineralize. They are found in the chamber. Now they can be free, adherent, or embedded. Free means freely in the pulp space. It is not related to any wall of the pulp. It is surrounded by soft tissue only. Adherent means it will be adherent to the dentin. It is attached to the wall of the pulp space, but it is not fully enclosed within the dentin. And embedded is completely enclosed within the walls, within the dentin. So they are false, they are calcifications, they are true, they are lined by odontoblasts, and they can be free, embedded, or adherent. Now the fibrodentin is material produced by the fibroblast-like cells against dentin prior to differentiation of new generation, that is going to lead fibrodentin. Dystrophic calcifications can also be seen. Inappropriate biomineralization in the absence of mineral imbalance is going to lead to dystrophic calcification. Root caries is very important epidemic of aging teeth. Root caries is a pathological process, occurs with quite greater frequency in older population than in any other age groups. If any geriatric patient comes, they have root caries for sure. Xerostomia is a common symptom in older adults. Along with loss of cementum, gingival recession, poor oral hygiene, high plaque indices, and periodontal disease, so that leads to increased risk towards root caries. They are asymptomatic, but if they are left untreated, it can progress into the pulp, resulting in local infection of the bone, of the gingiva, of the periodontium. If we have to take care of some endodontic considerations, the formation of the permanent tooth completes in 3 years after its eruption. So we know if a central incisor erupts at 6 months of age, then the root completion is going to be around 7, 8. So formation of the permanent tooth, if we talk of 6 years, then it's going to complete the root after like 7, 8, 9 years. So that is what they're saying. The formation of a permanent tooth completes in 3 years after its eruption into the oral cavity, but this does not apply to the apex maturation if we talk of. The remodeling and deposition of cementum occurring at the apex, it is an aging process. The formation, the maturation of apex is an aging process and occurs to compensate for the atreated enamel or due to physiological mesial migration of the teeth or as a response to occlusal forces. So as a sequelae to deposition, there is an increase in overall distance. Now the distance from the root apex to the apical constriction of the root canal is going to increase. If there is increased deposition of cementum, then the root apex and the final apical termination, that is your minor diameter, that distance is going to increase. So working length will be relatively shorter from the radiographic apex for an aged tooth than for a younger adult. This is a very important endodontic consideration to be taken care of, that if we talk of working length, that is going to be decreased from the radiographic apex because we have lot of deposition of cementum. Diameter of the apical foramen does not change with age. So this is all for today's topic, that is age changes. Hope you liked the video. Don't forget to like, comment and share this video, and don't forget to like and subscribe to our YouTube channel Dentomedia. Thank you very much.